Hi guys, welcome back to Code Master Coach, your medical coding tutor. Okay guys, we're continuing our review of the 2025 official coding guidelines for ICD-10-CM. This week we're on chapter 16, which is certain conditions originating in the perinatal period. These codes start with P00 through P96. My notes for this one just say when looking up a perinatal condition in your alphabetic index, refer to the main term birth or to the condition itself, whatever the condition is, and then a subterm underneath that identifies newborn or neonatal or fetal or infants or infantile. Some way of identifying that this is a newborn with the condition. All right, we start with A, general perinatal rules. And it says use chapter 16 codes. So let's look at the guidelines because it says refer to the guidelines. All right, chapter 16 says for coding and reporting purposes, the perinatal period is defined as before birth through the 28th day following birth. Because remember, the day you're born is day 0 up to the 28th day. So at day 29, you are no longer perinatal. It says the following guidelines are provided for reporting purposes. All right, general perinatal rules, use of chapter 16 codes. Codes in this chapter are never for use on the maternal record. Codes from chapter 15, the obstetric chapter, are never permitted on the newborn record. Chapter 16 codes may be used throughout the life of the patient if the condition is still present. So let me reiterate this because this is a big mistake coding students make. Remember, chapter 15 is childbirth, purpurium, pregnancy, childbirth, and the purpurium. Those are chapter 15 codes, and they start with the letter O. But chapter 16 are your perinatal codes, and they start with the letter P. For pregnancies, you'll never have a P code. And for perinatals or children, the perinatal period, you'll never have a code start with an O on those charts. So I always remind my students, don't put perinatal on the mother chart. Don't put the mother's codes on the perinatal charts. All right, we're down to number 2. Let's make sure, principal diagnoses for the birth record. Number 2 says, when coding the birth episode in a newborn record, assign a code from category Z38 for live-born infant according to the place of birth and the type of delivery as the principal first listed diagnoses. A code from category Z38 is assigned only once to a newborn and is at the time of birth. If the newborn is transferred to another institution, a code from category Z38 should not be used at the receiving hospital. A code from category Z38 is used only on the newborn record and not on the mother's record. All right, so we're talking about that principal diagnoses at Z38, only at the time of birth. Then when the baby's transferred, or if the baby does get transferred, even if it's the visit where they're born, that Z38, when they're transferred to that other hospital, you do not have to use that Z38. It's whatever condition they have and the reason for them being transferred. All right, let's look at number 3. Use of codes from other chapters. With codes from chapter 16 says go straight to the guidelines. All right, number 3. Use of codes from other chapters. So codes from other chapters may be used with codes from chapter 16 if the codes from the other chapters provide more specific detail. Codes for signs and symptoms may be assigned when a definitive diagnosis has not been established. If the reason for the encounter is a perinatal condition, then the code from chapter 16 should be sequenced first. Makes sense. Straight from that, we understand. Principal diagnosis is that which occasioned the admission to the hospital. All right, let's double check 3, straight from the guideline, and 4, guidelines. Number 4, use of chapter 16 codes after the perinatal period. Should a condition originate in the perinatal period and continue throughout life of the patient, then the perinatal code should continue to be used regardless of the patient's age. Regardless. Okay, that's good to know. All right, number 5, guidelines. All right, so let's look at number 5. Birth process or community acquired condition. If a newborn has a condition that may either be due to the birth process or community acquired, and the documentation does not indicate which it is, the default is due to the birth process, and the code from chapter 16 should be assigned. Now, if the condition is community acquired, a code from chapter 16 should not be assigned. Okay? Should not. If the condition is community acquired, then a code from chapter 16 should not be assigned. Because remember, chapter 16 codes are perinatal conditions. If it's community acquired, it's not a perinatal condition. All right, let's keep going. Let's see, we're down to number 6. Guidelines, straight from the guidelines, okay? Code all clinically significant conditions. All clinically significant conditions noted on routine newborn exams should be coded. A condition is clinically significant if it requires an evaluation, therapeutic treatment, diagnostic procedure, or extends the length of hospital stay, or increased nursing care and or monitoring, or has implications for future health care needs. Note, the perinatal guidelines listed above are the same as the general coding guidelines for additional diagnoses, except for the final point regarding implications for future health care needs. And I was going to say that too. If you look at this, anything that the patient comes into the hospital, not just perinatal, but a patient in general, they might come in for one particular condition, and then you're questioning whether or not to assign codes for the additional complications or comorbidities that a patient might have. Well, if they do any kind of clinical eval, if they run any further tests, if they do therapeutic treatment, if they treat it, put you on insulin, your sugar levels are too low and they need to give you insulin. Or if it's diagnostic, they need to check your blood sugars because you're diabetic. Or anything that extends the length of your hospital stay. Oops, you ran a fever today. You're supposed to be going home. Now you're running a fever. Something's wrong. Or it increased nursing care and or monitoring. Then those conditions, in addition to whatever the patient's coming in for, should be captured as well, coded as well. It says code should be assigned for conditions that have been specified by the provider as having implications for future health care needs. So I thought that one was interesting, has implications for future health care needs. As far as a perinatal, I can understand that. And the newborn coming in, if the physician, the provider documents that it could have implications on future health care needs, then we can code it. All right, we're down to B, observation and evaluation of newborns for suspected conditions not found. Let's look back at my handout. All right, let's talk about number 1, use of Z05, straight from the guidelines. Assign a code from category Z05, observation and evaluation of newborn for suspected diseases and conditions ruled out, to identify those instances when a healthy newborn is evaluated for a suspected condition or disease that is determined after study not to be present. And that's the key there. Because remember, with those Z codes means either they're observing or your status, or those are not full-blown condition codes. They let you know, oh, they're allergic to penicillin, oh, they're on oral meds, oh, there's so many weeks of pregnancy. But they don't tell you an actual condition. So in this case, they're saying Z05 is for observation of the newborn for a suspected disease or condition, but it's ruled, R-U-L-E-D, out. It's ruled out. It's no longer a concern. After study, it is not present. So then it's a Z05. You still sought healthcare services for it, but it was ruled out. So do not use a code from category Z05 when the patient is documented to have signs or symptoms of a suspected problem. In such case, code the signs or symptoms. So in this case, they're saying Remember, Z05 means you brought them in to observe them because you suspected they had a condition, but after study, they don't have the condition. Well, they still used healthcare resources, so it's a Z code. But this last part of this paragraph is saying, but do not assign Z05 if the patient did have signs and symptoms. In that case, don't code the Z05, code the signs or symptoms that the patient did have. Okay, you do have conditions to code. And in the second part of that, Z05 on other than the baby record or the birth record. Says a code from category Z05 may also be assigned as a principal or first listed code for readmissions or encounters when the code for the category Z38 code no longer applies. Codes from category Z05 are for use only for healthy newborns and infants for which no condition after study is found to be present. So in that previous heading where we're talking about when to use Z38 and that you can only use it on the birth record, but then what if the newborn is transferred to another facility right after birth, not to use that Z38, where they're saying here if you suspected a condition but it was ruled out, it's going to be a Z05. And so on that second admission, since you're not going to use the Z38, you can use that Z05 if no condition after study is found to be present. And number 3, Z05 on the birth record, a code from category Z05 is to be used as a secondary code after the code from category Z38, live-born infants according to place of birth and type of delivery. So if after birth you suspect a condition, then you can use the Z05 after the Z38 code. All right, C, coding additional perinatal diagnoses. Let's make sure I don't have anything listed there for C. Straight from the guidelines, so let's go back to the guidelines for number 1, assigning codes for conditions that require treatment. Assign codes for conditions that require treatment or further investigations, prolong the length of stay, or require resource utilization, which shouldn't be new to us because that's what we have to do anyway when it comes to coding our other conditions. As long as those conditions require treatment or further investigations, or if they prolong the length of stay or require resource utilizations, we capture them. Same thing applies for these perinatal conditions. Codes for conditions specified as having implications for future healthcare needs. Remember, this is the one thing that's added to the perinatal that we didn't see previously for additional diagnoses to code. It says assign codes for conditions that have been specified by the provider as having implications for future healthcare needs. This guideline should not be used for adult patients. I thought that was interesting, that note. This guideline, where you're assigning codes for when the provider says has implication for future care needs, should not be used for adult patients. All right, we're down to D, prematurity and fetal growth retardation. Let's see what I have for D. Straight from the guidelines, okay. Providers utilize different criteria in determining prematurity. A code for prematurity should not be assigned unless it is documented. Assignment of codes in categories P05, disorders of newborn related to slow fetal growth and fetal malnutrition, and P07, disorders of newborn related to short gestation and low birth weight, not elsewhere classified, should be based on the recorded birth weight and estimated gestational age. When birth weight and gestational age are available, 2 codes from category P07 should be assigned with the code for birth weight sequenced before the code for gestational age. And I meant to put a note on here that just states, and I'm going to put it on this other outline under D. What I'm going to put here is, how do I word this? Newborn immaturity implies a birth weight less than, or birth of less than 37 completed weeks. Gestation, newborn post-maturity, is a gestation period of more than 42 weeks. Newborn low birth weight, implies a birth weight of 1,000 to 2,499 grams, and a newborn extremely low birth weight implies a birth weight of 500 to 999 grams. I think we should note that so that you'll know about that. So I'm going to put that on there. Hope I typed all of that correctly. Okay, we're down to E, low birth weight and immaturity status. Codes from category P07, disorders of newborn related to short gestation, and low birth weight, not elsewhere classified, are for use for a child or adult who was premature or had a low birth weight as a newborn, and this is affecting the patient's current health status. Okay, so anything goes back to that guideline, factors influencing the health status and contact with health services. Any disorder of a newborn related to short gestation and low birth weight, or for use for a child or adult who was premature or had a low birth weight as a newborn, and this is still to this day affecting the patient's current health status, then we capture the P07 code. All right, let's go back and make sure I covered all that. We're at F, bacterial sepsis of newborn. F, category P36, bacterial sepsis of newborn includes congenital sepsis. If a perinate is documented as having sepsis without documentation of congenital or community acquired, the default is congenital, and a code from category P36 should be assigned. Now, if the P36 code includes the causal organism as an additional code from category B95 that's used for streptococcus, staphylococcus, and enterococcus as the cause of disease classified elsewhere, or B96 other bacterial agents as the cause of disease classified elsewhere, those codes should not be assigned. Now, if the P36 code does not include the causal organism, then assign an additional code from category B96. And if applicable, use additional codes to identify severe sepsis, which is the R65-2, and any associated acute organ dysfunction. And then stillbirth. Code P95, stillbirth, is only for use in institutions that maintain separate records for stillbirths. Because remember, a lot of times when the mother comes in and she has a stillborn, because it's not a live birth, a lot of facilities don't even have a separate record for the newborn because it never did make it to newborn status. And it says here no other code should be used with P05, with P95, because code P95 should not be used on the mother's record. It's only on to identify the fact that the baby was a stillbirth, and if you have a separate record, you use the P95. Okay, make sure I don't have any notes on G. Nope, just stillbirth. And then H. H is on COVID-19 infections in the newborn. For a newborn that tests positive for COVID-19, assign code U07.1 COVID-19 and the appropriate codes for any associated manifestations in neonates or newborns in the absence of documentation indicating a specific type of transmission. Now, for a newborn that tests positive for COVID-19 and the provider documents that the condition was contracted in utero or during the birth process, then assign code P35.8, other congenital viral diseases, and then the U071 for the COVID-19. And when coding the birth episode in the newborn record, the appropriate code from category Z38, live-born infant, according to place of birth and type of delivery, should be assigned as the principal diagnoses, because remember, we always pick up that Z38 first on the newborn record. All right, let's see. COVID-19. All right, we're down, chapter 17, congenital malformations, deformations, and chromosomal abnormalities. And that's next. That's chapter 17 of our guidelines. All right, guys. Thanks. I'll see you in the next one.